is just a huge honor for me today to be podcast interviewing David Gane, all the way from Vancouver, British Columbia. He is a graduate of the University of Western Ontario with an honors degree in physiology and pharmacology and a doctorate degree in dental surgery. David has authored many publications and technique videos on digital dental imaging and has lectured nationally and internationally on this topic. He is a recognized leader in the dental profession and is also a corporate executive with extensive experience in dental technology. He is the former vice president of dental imaging for Carestream Dental and has served in executive capacities with a number of dental companies, including Practiceworks and Kodak Dental Systems, and is the founder of Orbit Imaging, Inc., a company that owns and operates dental imaging centers in Vancouver. Dr. Gane currently serves as CEO of LED Medical Diagnostics, the manufacturer of the VELscope and the parent company of LED Dental and Apteryx. Is that how you say it? Apteryx, Inc.?
Apteryx, yeah. That's an Australian bird.
And seriously, God dang, David, you're amazing. I mean, you're an amazing dentist, and when you were with Carestream and Kodak, I mean, those were some of the. You were the former vice president of dental imaging for Carestream, which used to be Kodak. I mean, that's God dang, they could have got any dentist in the world for that position, and you scored that. I mean, that is amazing. And Practiceworks, so Kodak bought Practiceworks, which owns SoftDent, which I've been on for 30 years.
Correct.
And a bunch of others. And then they sold it to Carestream, which is in Canada, right?
Carestream, yes, private equity. Carestream was the Kodak Health Imaging division. Of course, dentistry was a part of that. But that's a private equity group out of Toronto called Onyx.
Onyx. How do you spell that? O-N-Y?
O-N, oh, that's a tough question. O-N-Y-X, I believe.
Yeah.
And they just recently divested about a month ago to two other private equity firms. So Carestream Dental was just sold.
So it's really weird because usually the exit strategy of a venture capitalist is to take it public. But I notice there's a whole different strategy. It's kind of like a hot potato. Like you see it with DSOs. Like there's not one DSO in America that's publicly traded. And I don't think Wall Street would take any of them. I don't think Heartland, Pacific, Aspen, I don't think any of them go public. But what you'll see is they'll get venture capital and say the 5 million range, and their goal is to flip it to 10 million to a venture capital in the 10 million range. And then that guy buys it, and then his goal is to flip it to someone in the 20 million range and the 40 million. It's like the hot potato. It's like nobody wants to keep it. Everybody wants to just flip it. And so interesting deal. So gosh darn, we could talk about so much. I want to start with something completely off the deep end. You are the manufacturer of the VELscope.
Yes, absolutely.
And you make that now?
We do. We manufacture in Burnaby, British Columbia.
So, I mean, what I've never understood for 30 years is that dental insurance, like Delta's the big dog. I mean, they're the biggest, they're the 400-pound gorilla. They don't cover oral cancer exams. I bet you, because VELscope is very similar in technology to the cervical uterine cancer technology. I mean, they were 30 years ago. I mean, I remember seeing it where they swabbed the tissue with toluidine blue. They were looking at the same. It was the same thing, especially in the 80s. And I imagine if medical insurance companies said, you know what, we're going to quit covering vaginal cervical cancer exams in women. Oh my God. I bet the CEO would have to resign. He'd be written off as some sexist, animal, crazy nut job. Yet here we have, now it's 2017, and insurance companies don't cover it. Medical insurance companies don't cover it. And 50,000 Americans a year die from it. Why is that?
It's a good question, Howard. Actually, more people die from oral cancer than they do from cervical cancer. And we all know that, most ladies, they get screened annually. And in dentistry, opportunistically, we're right in the right position to be able to screen these patients. And it's not happening. And as you say, the carriers don't reimburse it. And reimbursement does drive adoption of the technology. We all know that. Dentists are in a business, and they need a clear path on an ROI. Delta Dental, I would guess they don't play on the medical side. That's why they don't cover it, because early detection, saves lives. It also reduces morbidity. And I think I haven't done a full analysis, but I think there are some dental insurers that do cover it, and they also play coincidentally on the health side. So, I'm sure their strategy is if we create some reimbursement, and we're seeing in our customer base about $30 about a third of the time. But I'm thinking that those dental carriers that do reimburse are also playing on the health insurance side, and they'll figure out they're going to have to pay now or pay later much more. So I'm sure that's just a business decision. But
it's kind of interesting what you're saying, because the doctor, the big buzzword is the oral systemic link. And
absolutely.
all my other physician friends say that the same concept is coming to them, like the internists are starting to realize, that they're connected, the cardiologists. So that oral systemic link is being played out with every other body part of all 58 medical specialties, all 9 dental specialties. But it looks like it should be in the insurance. It sounds like a standalone dental insurance company is not as holistic as someone part medical, because I remember listening to the past executive director, I think, of the ADA. His name was Brenner, and you know Brenner. You know who he's with? I think it's Connecticut General or whatever. But they were they have, I think it's Connecticut General. Is it? Can you look at Brenner on But anyway, they were talking about how the medical side was most interested in the dental side, covering pregnant women, because if they had gingivitis, periodontal disease, and dropped a preemie, their average preemie cost was $1 million, and the number one thing they could relate it to, besides smoking, was gum disease.
Periodontal disease.
So if you're smoking and have gum disease, I mean, they want you to see a hygienist and someone talk you out of smoking, because they have $1 million at stake if you drop a 1-pound frog,
Yeah. It's interesting because we know that patients want to be screened. There's good data out here from the Head and Neck Cancer Alliance, and there's a lot of information out there, but dentistry has not done a good job, organized dentistry, in screening patients. And if I could just read a little data point here that I think is interesting. 58% of U.S. consumers know little or nothing about oral cancer. 65% of American consumers are not aware that HPV is a risk factor for oral cancer.
What percent? 65?
65%. 83% want to be screened. Of patients want to be screened at every checkup. Only 37% of U.S. patients report ever being screened at their last checkup. And it just goes on and on. So we did an interesting little experiment where we know that pharmacies now have gotten rid of the tobacco, and they're all about health and wellness, and they're doing screenings, right? They're doing blood pressure.
You mean CVS quit selling cigarettes?
Yeah, and up here, just overall, pharmacies are more health conscious and more into well-being. And so we approached an 80-chain store up here in Vancouver market, and said, hey, your pharmacists are doing, injections for flu vaccine. They're doing blood pressure screening. How about doing some oral cancer screenings? And they thought about it, and it didn't take much, and they said yes. And they've been doing them now for the last 3 years. They love the demographic that's coming in. Of course, they advertise it. They charge for it, and they charge an average of $25 per screening.
Is that Canadian or U.S.?
That's Canadian. We're up to 80 cents today.
So $25 Canadian, and what would that be in U.S.?
Yeah, say $22, 20 bucks.
20
anyway,
bucks.
Patients are willing to drive to the pharmacy to get a screening. We use the VELscope. We're putting dentists and hygienists in there because the pharmacy college is kind of a little unsure about their scope of practice in this regard. Any findings are triaged right to oral medicine or back to the dentist of record, and it's been working great. So my point here is dentists shouldn't be afraid to either give it away and incorporate it into their comprehensive oral examination, or don't be afraid to charge for it if that's your thing, because people are more than willing to pay a fair fee for that service.
Well, the reason I was asking how much it was in U.S., what are the disposable costs? What are the sundries and supplies costs in a VELscope oral cancer screening?
With our device, it's around just over $1 would be the disposable cost. And we've made those disposables very robust, and I wouldn't be surprised if people were reusing them. But it's about $1, just over $1
Do
per
you have
use.
a good YouTube video that shows the VELscope oral cancer exam?
I did, and I thought, I'm a dentist. I'm still licensed. I don't practice anymore, but I thought it's probably embarrassing for a dentist to say, I forgot how to do that. And so I contracted with a buddy who's a very famous oral medicine doctor here locally, Samson Ing, and I did create a YouTube video, and I asked him to do it. And it's him doing an oral cancer exam, tactile,
How long
comprehensive.
is that video?
I think it's about 6 minutes. Doesn't take
Okay.
long to do
Do
that.
you mind emailing it to me, and then right now we'll splice that 6 minute video in so everybody watches on YouTube and Dental Town or listening to it can hear that exam now.
Absolutely, and
I think that'd be a really good deal.
it'd be a great service to the profession because it's simple once you know how, but until you know how, people I think are tentative to do it properly.
Hello, my name is Dr. Samson Ing. I'm a board-certified specialist in oral medicine and oral and maxillofacial pathology. In this video, I would like to show you a straightforward exam that helps your dentist not only evaluate the overall health of your oral cavity, but also screen for signs of a potentially deadly disease, oral cancer. During this procedure, your dentist examines both the inside and the outside part of the mouth, looking and feeling for anything abnormal. Most findings usually represent infection, inflammation, or some sort of trauma. However, there are also situations that could represent precancers or even cancerous changes. All of these abnormalities benefit from early discovery, allowing your dentist to manage the conditions before it becomes a more serious issue. Finding oral cancer early is absolutely critical and may even save your life. Let's get started. Now, today we are going to complete a full oral health assessment.
Okay.
In the history, you indicated you have a sore in your mouth.
Yeah, I've got a bit of a sore patch. It's on the right side of my tongue, a bit near the back.
How long have you had it now?
2 to 3 weeks.
What have you done so far?
Well, nothing too much. It's sort of been coming and going, so I've sort of been hoping it's just going to go away.
I see. So we are going to look into it as well.
Okay,
Now,
great.
how is your health otherwise?
Oh, it's good, thanks.
Good. Do you smoke?
No.
Do you drink?
Occasionally, maybe, wine with dinner, something like that.
Before I look inside your mouth, I'm going to look outside around your head and neck. Can you rest at the back? Thank you. Great. I just want to make sure there's no lumps and bumps on the skin. Great. Can you open your mouth? Can you close? What I'm doing now is to make sure there's no swelling gland around your jawbone area and around your neck regions. Great. Can you swallow? And do it one more time, please. Great. Thank you. Okay, to start off, I'm going to look into the lip. You close a little bit. Great. Perfect. I'm going to look into the mouth. You open. I start off with the side of the cheek. Look into the lower lip and also the other side of the cheek. And then go to the upper gum on both sides. The palate look absolutely healthy for me. Thank you. Now you close and swallow. You open and you say ah. Perfect. Thank you. I'm going to look into your tongue. Can you stick out your tongue, please? Great. The side of the tongue looks good. The other side of the tongue is good as well. You close and swallow. I'm going to feel around the bottom surface of your mouth to make sure there's no lumps and bumps. Great. You open again. I'm going to feel around the palate and the jawbone region as well to make sure there's nothing else. Great. You bite together. And thank you. So right now I'm going to use another light to look into your mouth again. Okay?
Okay.
Before we do that, I'd like you to put these eyeglasses on, please. You open your mouth, please. Again, I'm going to do the same thing and using this light to look into the both sides of the cheek, the roof of the mouth, and the floor of the mouth. Can you roll your tongue back, please? Thank you. Great. You close and swallow. Great. I then look into your tongue again. Can you stick out your tongue, please? Great. Look at the side of the tongue and the other side of the tongue. Great. Thank you. Good. Now you can take off your eyeglasses now. Good. I'm going to take a picture of the sore area that you talk about. Now you open your mouth, and I need your help to help me to hold on to this cheek retractor for me. Great. Can you stick out your tongue, please? And to that side, great. Good. Can you stick out your tongue again? Great. Good. When this oral exam is conducted regularly, particularly with a device that helps your dentist to see things which might otherwise have been overlooked, you have a better chance of discovering an abnormality sooner and treating it with a better outcome. From time to time, your dentist or your hygienist will ask you to come back for another checkup, or even refer you to a specialist for additional care. They are routine and an essential part of the process. I hope you can see why an oral exam is a very important part of your routine dental checkup. Remember to ask your dentist about it on your next visit.
Well, how many Americans do you think die each year from oral cancer?
I got the facts here, Howard. So there's 600,000 new cases a year. That's a worldwide. In the U.S., 10,000, with about 40,000 new cases growing annually.
So
10,000 died
Americans,
this year.
10,000 what, new cases in America, or 10,000 die?
10,000 died. 9,570 will die of oral cancer, pharyngeal cancer this year.
Of oral pharyngeal?
Yes,
And
oral and oral pharyngeal.
Oral cancer and oral pharyngeal.
Correct.
And then how many new cases? So 9,570 will die from oral cancer and oral pharyngeal cancer. And then how many new cases?
48,000 new cases in the U.S. this year, expected this year.
And what do you think early diagnosis as opposed to late diagnosis would do to that 9,570 if they were all caught in stage 1 as opposed to stage 2 or 3 or 4?
Well, stage shifts are huge, as you know. So again, I'm just quoting data from the Head and Neck Cancer Alliance. 40% of those diagnosed with oral cancer die within 5 years, and that's due to the late stage finding. And early diagnosis, they say, will more than double the chance of patient survival. So
yeah, that's what's weird about dentistry, because people always tease them. They'll say, "Well, dentist, that's not a real doctor." And I always say, "Well, Dr. Pepper's not a real doctor. Dr. Seuss wasn't a real doctor. Dr. Dre's not a real doctor." But when you look at dentists, they kind of act like they don't want to be a doctor, because when they look at the almost 10,000 Americans die of oral cancer, and that's the one thing they don't do and their insurance doesn't cover. And then what I can't believe is when you look at the flu, 8,000 is like the least number of deaths in America in like the last 10 years, and it'll soar all the way to 48,000. And when they look at those 48,000 people that died, the last top 3 points of entry into the healthcare system always includes the dental office. And so here's a hygienist with a 4 years degree, and if she was if grandma would have went to the hospital, or the physician, the nurse would have given her a flu shot. And here's the hygienist, trying to see if she has gingivitis. Grandma ain't going to die from gingivitis, but you might not see her 6 months later from the flu. And then when the boards vote on whether or not the dentist can give a flu shot, the dental boards are the ones that voted down. I mean, can you believe that? I mean, you would think that someone else was doing this to us. It's like the guy living under the bridge is the one smoking the meth, and the only state out of 50 where they finally allowed dentists and hygienists to give a flu shot was Tennessee. And and it's like
there's a total disconnect, and you're right, dentistry is driving it, and it started right at the beginning. I forget the name of the book, but I'll send you the link. There's a great little book as a Washington lobbyist was writing about the disconnect between the oral cavity and the rest of the body and how it started. It's a wonderful read. And, if I go to the dentist, they don't ask me if I've been exercising and kind of working out and taking care of myself. And if I go to the doctor, they don't say, have you been flossing lately? So there's a real disconnect there. And I think you're right. Dentists don't want to own it. Again, they don't see a reimbursement model for it, but it's right in their wheelhouse. And it's unfortunate that periodontal disease is now being found through all these new amplification techniques and new knowledge to be causing everything from rheumatoid arthritis to breast cancer to heart disease. But that's the portal. That's our world. That's where we live. And hopefully that'll change. But we're doing a bad job of screening for sure. And if we could just identify these oral mucosal diseases as pre-malignant or not, we could make a big impact.
Man, it's been a long time since I heard wheelhouse. Wheelhouse, baseball, of the pitch, within the zone.
That's not a northern term either. I've got a southern partner, and I pick up a few from him. It's
baseball within the zone that is most advantageous for a batter to hit a home run. Within one's area of expertise or interest, there are some subjects that are in your wheelhouse. I don't think I've heard that term since I was 10. So yeah, I mean so what are you most passionate about now? VELscope's been out. I mean that's been out for 30 years.
No,
not 30.
7, 8. Fluorescent visualization technology for other parts of the body, like the lung, have been around.
Well, what was the one in Phoenix where I live? There's Phoenix, Arizona. There was an oral cancer screening company.
Visilite?
Yeah, Visilite.
Visilite has been around longer. It is, it had the light stick and the astringent rinse.
Right.
Yeah, similar technology.
And are they still in business or are they gone?
I think they're still there in some form. And I don't want to misspeak, but it may have been Denmat that picked up the assets of that Visilite. But we're the largest player right now. We've got what the largest player has in terms of user base is about 16,000 globally units. So it's pretty sad in terms of
16,000 units globally, and how many of those 16,000 are in the United States?
I'd say 90% of them.
90%.
90% of them. We just picked up, in Southeast Asia and China, there's carcinogenic foodstuffs that they like to chew, stimulants, areca nut, betel nut. So they've got a big risk factor over there. So recently we did sign with a large distributor over there. So we're making some inroads in China. Same thing in India. Similar type of dietary habits that really drive much higher, findings of premalignant and late stage tumors. But it's it's handheld. It's easy to use. Howard, the big news on the VELscope is that we just finished a 5-year double-blind clinical randomized at 9 oncology centers, and what they were doing is they were using the VELscope to guide the surgeon for surgical removal of the cancers. So 400 plus oral cancer patients, and they divided them into 2 groups. And the experimental arm, they used the VELscope, the oncology surgeons, to remove the lesion. And in the control arm, they just used traditional methods of palpation and incandescent light. And then they measured recurrence of the disease over 5 years, and now we're in year 6. Most of these oral cancers, they recurred about 40% by year 3. And so, that's why it's such an aggressive surgery. They take a large rim of healthy tissue in hope of, excising the lesion in toto. We did a retrospective study that showed that the recurrence of the disease goes down from about 35% down to about 6% if we're using visualization technology to guide the surgeon's approach, and a more conservative approach at that. So this data will be published in the next 60 days on a 5-year trial. So we're real excited about that. And we think the prospective study at these 9 oncology centers will mirror our retrospective studies. So that could be big for moving a VELscope from screening to actual treatment.
What are you seeing the difference between oral cancer and oral pharyngeal cancer? Is that the terminology you're using?
Oral and oral pharyngeal.
And oral pharyngeal?
So the risk factors, traditional risk factors of tobacco, whether you chew, you vape, or you smoke. Smoking. Of course, smoking and drinking is double bad, and then alcohol use by itself, and the new risk factor, of course, is HPV 16.
But is that oral cancer or HPV for oral pharyngeal cancer?
Both, but mostly oral pharyngeal.
Okay, and that's HPV 16?
16 and some of 18, I believe, but mostly 16. And I just read on Flipboard the other day that 50% of the men in America have or are infected with HPV. So that's a pretty big number. Of course, Gardasil will change that over time.
Okay, but there's
But here's a stat for you that is really troubling: is the largest rising group of oropharyngeal cancer patients is non-smoking, non-drinking, and it's totally due to sexually transmitted disease of oral sexual activity, and it's in the adolescent group. So the whole demographic is changing, which means dentists now have to be more aware and not just screen if they're screening at all in that elderly at-risk group of drinking and smoking, but the entire population over the age of sexual consent.
But again, our dentist doctors, I mean, what percent of the doctors have ever had a Gardasil conversation with their patients regarding their pediatric patients under 10 years old?
I would say very low. They're uncomfortable with that.
Well, I mean, so they're uncomfortable with the conversation, but they're okay with 10,000 deaths a year?
Apparently.
And the other thing is, when they're talking about oral sex and HPV and all that stuff, it seems like they really, I mean, it could just be kissing, right?
It could be. It could be. Again, I'm not an expert, but I think the vast majority of these infections are from oral sexual activity.
So not just kissing.
Not just kissing, no.
I wonder if that's because no one just kisses and they all. But anyway, to me, it seems like when I look at the research where a standard kiss will transfer 80 million microorganisms, bacteria, fungi, and viruses. I mean, if somebody's infected with something, I don't think it really matters if the fluid was coming from the mouth or downstairs or whatever. I mean, you're trading fluid with some other member of your herd,
Yeah, exactly. And this fluid, which has largely been a nuisance to us as dentists, I think is going to prove to be the new superfluid. Again, with all these amplification techniques and these new biomarkers and, these proteins, saliva is pretty much a real-time fluid. So there's a lot going on, and you can tell in the moment. And you can correlate some of these biomarkers, whether they're proteomic or, proteins that the body's excreting, or actually viral particles, or even, cancer cells at the point of care, to be able to, facilitate or bolster. VELscope's a very sensitive device. It's not very specific, but then when you start adding these biomarkers and these point of care tests in conjunction with it, it can get much more higher specificity. So that's kind of where I see it going. And there's some really great little companies, and Dr. Wong's doing good work in California, and, Vigilant Bioscience, and there's a few of them now coming to market with these point of care tests. I was surprised. Point of care Zika test, $2. Spit and positive. It's very binary. You have it or you don't. $2, and in 10 minutes. HPV, HIV spit tests, and that's going to be.
Are you guys selling those too?
No, I have a professional interest in that because it's tied into early diagnosis of oral cancer lesions. But I think it's going to take the profession by storm pretty soon, because where do you harvest spit? At the dental office.
You should create an online CE course on Dentaltown about this. We've put up some 400 courses on Dentaltown since 2004, and they're coming up on 1 million views. Old guys like you and I read textbooks and go to conventions, and there's 250,000 people on Dentaltown. But when we came out with the app, 50,000 people downloaded the app, and those were all the millennials. And while you and I read textbooks and go to conventions, the millennials are on these apps. And oral cancer is everything. You should create an online CE course on Dentaltown. I think that would be.
Well, I just did a program on salivary diagnostics for my own professional interest, and I just delivered it to my study club. So I've got a fresh program. It's about an hour, and I'd be happy to do that.
Perfect.
Nice to leverage the material.
So I'm Howard at dentaltown.com, and the guy that does online CE is Howard Goldstein. So he's Hogo, Hogo, at dentaltown.com. Ryan, will you email David and Hogo? Yeah, that would be amazing, because I'm trying to I'm trying to be a leader and steer these doctors that, it's not all about gingivitis. I mean, there's oral cancer. How do you say that vaccine? The Gardasil?
Gardasil.
Yeah, it's just I think it's just how do you spell it? Guard.
Garddisil, Gardasil. That's the trade name.
Gardisal.
SIL, I believe.
Yeah, Gardasil 9. To me, it's just so sad that nobody in dentistry. I mean, there's 211,000 Americans who have an active license to do dentistry, and 150,000 of those are general dentists, 32 hours a week or more, and 30,000 are specialists, 32 hours a week or more. And this is their damn cancer, and they need to own it. And who's supposed to own it? The primary care. And let's talk about primary care. I mean, I almost try not to laugh. Every year I get a physical, and my doctor I've been going to forever, when he gets in my mouth, he says, open up, and he takes a popsicle stick and a light, and he says, say aw, and I say aw, and then he's done, and then he throws the stick away. And I'm like, hey, I've been a dentist for 30 years. What the hell did you just do? I mean, shed some light on your homie here. I mean, I don't know. Yeah. I couldn't have done anything. And so what's the doctor going to do? The dentist says, oh, I'm really a doctor, but the primary care physician owns oral cancer? I mean, give me a break. I mean, they really, and I think an online C-course would help that, but dentists should be given the Gardasil 9 talk. They should be given brochures to all the patients. If they can't have a conversation about oral sex, they should actually go back and turn in their dental degree and go live in a bubble under the basement of their mom's house, and at least give a handout or have your dental assistant or hygienist talk about it, and they should give a flu shot. And I think dentists should just start giving the flu shot. I mean, what is the government really going to do? Are they really going to come arrest a dentist and put him in jail for giving grandma a flu shot when you can go to Walgreens or CVC and the pharmacy tech who went to school for 9 months can give grandma the flu shot, but doctor and hygienist can't? I mean, it's insanity.
Ridiculous. But you brought up a point there about the hygienist. I think the big opportunity in the short term is to leverage the hygienist because they have a pretty tough job there. They're with the patient for a long time, and I think most of them do care about the patient's health holistically. And they're looking at the soft tissues. They do like technology to be able to help them and bring it to the attention of the clinician. So I think probably the secret weapon in the short term would be to leverage that hygienist base.
Absolutely. Yeah. And I almost think it'll take some lawsuits before the dentist will react. I almost think someone has to get sued because she took her daughter to this dentist every 6 months from birth to 18, and then she went to freshman year at ASU and died of oropharyngeal cancer, and nobody told her anything. I almost think.
Who's doing good work in this regard is, Brian Hill at the Oral Cancer Foundation?
I do not.
Brian is a stage 4 survivor. He was in the dental trade, in the business, and he's pretty much devoted his life at this point to
what's his
oral
name?
Cancer awareness. His name is Brian Hill.
Oh, does he have the Oral Cancer Foundation?
Yeah, he does.
Okay,
and he's doing some really incredible things in marketing, low-cost marketing, sponsoring a rodeo rider, doing oral cancer screenings, among the beer and the smoke at the rodeos. Sponsored the rider, doing great things at surf competitions, and all young people, and just creating that awareness of HPV as a risk factor. One of the the soap opera actresses actually did get oral cancer and was able to convince the producer to keep her on the show and let America see what this disease is all about. And so he's very, very creative, and he's doing some fabulous work about educating the public on this disease.
That is amazing.
So we like to support the Oral Cancer Foundation wherever we can.
Nice. So what else are you passionate about?
I'm an imaging guy, and VELscope is an imaging device. It was time for me to leave Atlanta. I was there with my wife. I said we'd be there for 2 years, and after 13, she said I'm leaving. And so it was time to get back to Vancouver, but I've always been an imaging guy. It was, you remember Dick Barnes?
Oh, yeah.
You remember Dick and his 5 slides?
I was Barnesified.
I was Barnesified. That turned me on so much. I started practice. I bought a camera and I made my own 5 slides, and I took pictures of everybody because I had time to do it. There was not a lot of patients, starting from ground zero, and I quickly found out that I could really sell a lot of dentistry that I didn't really know how to do, and the slides worked, and really that got me going. And then of course I took Omer's course on case presentation and how to close them, and then I had to go learn how to do the dentistry, and I became such a passionate person about imaging. I started an imaging software company, and I don't know if you remember Image Effects or Picture Perfect and DICOM imaging systems. Those were foundational products that we created. I got into the software business. Dentistry, you only make money when your fingers are wet. So it kind of sounds like an Omerism, but I thought, well, software is better because, you could just print it on discs and, it'd be easier. And so I did that. And of course, I ended up selling my company to Practiceworks in 2002. And at that point, they were doing the consolidation. They were buying SoftDent, and they bought north of 30 companies in about a 2-year period. It was pretty intense. And I was one of those acquisitions, and then
sold it for how much? How much did Kodak pay for it? Was it
500 million cash?
It was $500 million
in 04.
And my jaw is still on the floor that nobody could believe Kodak wrote $500 million. Those guys, that was crazy. But they did
just
it.
Before Kodak bought it, we acquired Trophy Radiology. So this was a real thrill for me, being an imaging guy. So we went to France and we bought Trophy. And of course, Francois Moyen was a big hero of mine, and he had the original IP. And so we had all of these. I would think it'd be, SoftDent, to Practiceworks, Computer Age Dentists, OrthoTrack, WinOMS. I bet you we had 60,000 user base. And then we went and bought Trophy. They were divesting. And then Eastman Kodak, that was messing with their business because they had 90% market share in film. And I bet you that hadn't closed, but we bought them for 1 times revenue. It was a great deal. And so we grew from early stage to about 120 million through acquisition and a little bit of organic growth. As soon as we bought Trophy, they were on it. And I bet you a year didn't go by, and our leadership sold for $500 million cash. They only held it for 2 years, and they sold it, private equity. So, we all know the Kodak story. It's a sad story of not being able to make the transition in a timely way or at all, analog to digital. So,
well,
but it was
tell
exciting.
the millennials, tell the under 30 the Kodak story. Why do you think they owned film? Why do you think they missed digital?
Imagine if they had 1/10 of a cent of every picture that was ever taken by a smartphone right now. They'd be the biggest company on the planet. But they missed it. I think it was their senior leadership. They just missed it. They were too focused. So Kodak had 3 business units. They had the movies, they had consumer photography, and they had healthcare. And the first thing they jettisoned was healthcare because they couldn't be a major player because they were running into problems. So they had the movies. They were still shooting on celluloid probably. And they never, in the consumer photography, they never made the jump from film. Film is high margin. I don't know if they got greedy. Dental film, super high margin. They stuck with it too long. And, once digital radiography came along and they started losing market share, us just consolidating these practices and now, solving their back end digital problem, we became a perfect target. And of course, my partner and I and other leaders on the team, we knew exactly that was going to happen, probably before they did. They had to do it, but it was too little, too late, and the rest is history, right?
Sad.
They blew it.
And then Xerox,
one of the most iconic names in the planet, or brands, right?
And Xerox basically invented all the stuff that was in Steve Jobs' deal. I mean, Steve Jobs tried to make it a legend that he and Wozniak invented all that shit in a garage, but that was all Xerox technology and Park Research Lab.
Yeah.
And every time they brought the technology back to Xerox, they said, well, what does this have to do with the copier? I mean, they just could not see that there could be another company in there.
Yeah. Yeah. No, it's good to look back and see what happened, so those mistakes aren't
So
made again.
you've gone from film to 2D to now 3D. That means we must be getting old. when you
Yeah.
practice through film, 2D, 3D, I still remember the greatest invention of the on the 2D pano was when they did the upgrade to where they put a R on one side and an L on the other. I thought that was absolutely the greatest radiographic invention of all time. I did not see the 3D coming.
Now, do you remember, and again, I had the good fortune to meet Francois Doré recently, came out of retirement to do another 3D imaging project in dentistry. But back in the 80s, Francois at the Chicago Midwinter, probably about 88 or something like that, mechanically digitized a prep tooth with a little wand that he had to touch every surface, created this digital pattern, and then designed and milled a crown and seated it on the floor of the trade show. So we were in 3D in the 80s. He was so way ahead of his time. It was not funny, and so I've always become interested in 3D. And at Carestream, they made the 9000, which is the small field 3D. And I remember being the VP, and I remember poo-pooing that thing. It's like 3 centimeters by 4 centimeters. And I'm coming from, comprehensive care, and just, you'll never sell that. That nobody will ever buy that. And it's a pano too, right? And I was so wrong. We sold thousands and thousands and thousands of those, mostly to endodontists, right?
Right.
Became the standard of care real quickly. And that machine sold. It opened the market for 3D at a affordable price point. And it was just a great little machine. I still have a couple at my imaging center. But 3D now is so exciting. Really, what's happened is it's just transitioned, imaging in dentistry from the realm of just pure diagnostics to image-guided treatments. Look at Invisalign, and look at image-guided implant placements, and it's just getting going. Image-guided snoring appliance. Just using all this data. Optical impression scanning in full color, merged, consolidated with DICOM sets, merged with, photogrammetry of, full color of the face. It's just amazing, to the point now we're so close to a patient-specific virtual model that we can diagnose and treatment plan and almost treat the patient in simulation like they're right there when they're not. So I still have as much passion for imaging as I've ever had, and I think it's getting more exciting and more fun than ever.
So you talk about the commoditization of intraoral sensor technologies. What do you mean by that?
I bought one of the first sensors. You could barely get it in your mouth, and it was like, more than $10,000. And I know what these things cost to make, and so does everybody else in the industry. And it's been very expensive for clinicians to buy these. And, to be frank, to this point, they've been somewhat fragile. And so that's really slowed down adoption. And right now, all the patents of Francois Moyen are away. So everybody has access to the scintillator and the optical fiber, and getting a nice clean diagnostic image with not a lot of dose, a lot of noise. And so any factory can make these now. So what I mean by that is probably sensors right now are due for a price correction. They won't be able to substantiate these high margins, and these high costs, which I think, at a lower price point with a product that's as good or better, I think that'll drive further adoption to digital, which is good for the patient and good for the practice. So, that's really the focus of our company is, we're a unique little imaging company. We're public, but we're small.
Where are you traded?
On the Toronto Venture Exchange. We're looking to uplist in the near future to hopefully to the NASDAQ. But right now we're on a lot of people's radar. We just closed an acquisition in February of Apteryx. And Apteryx is a wonderful little company. My partner and I have tried to buy them a couple times before. We've known Kevin, the single shareholder owner, for 20 years. He's built a wonderful company. He's got tens of thousands of dentist customers, and he's got
that's
the
Apteryx?
Apteryx. It's
Apteryx?
actually Apteryx is an Australian bird. Maybe you'll see one there next week.
I'm after I get in talking to you, I'm going to the airport and flying to New Zealand. I mean to
Australia,
Melbourne and Australia with Ryan. So Apteryx, and what is Apteryx?
Apteryx is a dental software house. So they make dental imaging software. They are suppliers to the U.S. military, the Navy, the Air Force, all of their user base, or all their naval and Army bases and sub bases worldwide. And they've got a very large user base because basically their secret sauce to their software is it's open software. That means it's agnostic to hardware devices. It's full DICOM, it's full open. And if you look at, many, companies in dentistry and imaging like Sirona or Carestream or the Danaher products, they're closed proprietary ecosystems. So this approach of having an open architected software system allows, for instance, the U.S. Army to use their entire inventory of sensors globally and not have to refresh their sensors by using the Apteryx software. So a common platform. DSO is another great example. We're very popular in the DSO market because these closed proprietary systems, something fails like a sensor, you're pretty much captive to that manufacturer. You don't like their pricing, you don't like their support, too bad. You can't afford to leave because you'd have to refresh your entire inventory of hardware. Apteryx over top allows you to continue to leverage your existing inventory of imaging hardware, pens, cephs, sensors, while adding the new sensor of your choice, which I believe we're going to be in the running because we have this new sensor line that's as good or better than anything out there at a much different price point, a value
And
play.
you said Apteryx is named after an Australian bird, but is it an Australian company? Because the address on the website is Akron, Ohio.
Based out of Akron, Ohio. I forgot to ask Kevin where he got the name, but he liked that name. But I did look it up, and it is an Australian bird. The other thing that is very unique about Apteryx, they got a very large user base. We were very happy with that. And of course, Howard, they're all digital dentists because they're using digital software. But Apteryx also has 40 patents in the dental imaging space. And a lot of them are surrounding their software IP. So at the same time, their software is agnostic to hardware. They integrate well with all the dental practice management softwares. So it's a great solution. And, many dentists have found it. It's very well priced, support's very reasonable. That's how they got such a large user base.
And what's the owner's name, Kevin?
His name's Kevin, is the son of a dentist, and that's how he got into dentistry.
What's his last name?
Cruz, C-R-U-C-S. Kevin Crux, C-R-U-C-S. Great guy.
Out of Akron, Ohio.
Akron, Ohio. Lives down the street from LeBron.
Do you
Great guy, very smart.
A good podcast?
He'd be an awesome podcast.
Can you fix this up?
Absolutely.
Yeah, email him and CC me and Ryan, and we could have him follow you. So you're thinking
he's got a great story to tell. He's been in the business for 20 years, and he's seen it. And
right now you're in the midst of buying him, right?
We closed the acquisition in February, so we're done. He's integrated into our team.
And is he going to stay on? Yeah,
absolutely.
Nice. Very, very good.
So it's a nice little, it's transformational to our company for sure. And we're excited because, he's a profitable company. He adds revenue, he adds earnings, he adds users, he adds IP, and he gives us this really unique piece of software that allows us to, really tailor our products to the enterprise groups and then DSOs. And so we're real pleased with that acquisition.
Nice. So what else has got you passionate? What else are you excited about?
I'm excited about so many things. Right now, we're growing the business. It's a relatively new venture. When I joined the business, right at the beginning of 2014, we had one product. Now we have a whole portfolio of imaging products. So we're a full-on imaging company. I've been in the imaging business, as a big fish in a small pond in my own company with Practiceworks. But I'm real excited about LED medical and the transformation that we're making. And, it's be nice to get on some more radars and have people out there know kind of what we're up to, because I really think that when people look under our hood, they're really going to like what they're going to see about what we're trying to do.
Talk about intraoral scanners and CAD/CAM chairside milling. What are your thoughts on that?
The old days, if you believe the powers that be, the CERAC and the E4Ds of the world were going to kind of take over, but it seems like they capped out at about 20% market share, and I think that's going to be dropping down. I think dentists are a little kind of control freaks, a lot of them, and they want to kind of control the whole process from scan, the plan, and even do the lab work, which never made any sense to me. But now with these intraoral scanners being optimized and refined with next-gen technology, these optical scanners can take an impression much faster than impression material, much more accurate, full living color. And what you're seeing now, I think, in the global market is no more chairside milling, but just these scans go up, and it's like Priceline.com on a design. It's Priceline.com on an open mill. So it's really going to drive the lab deliverable costs down, in my estimation. And of course, a lot of these mills and design teams are offshore, so they can be done during the night. So I think my vision of the future is we're not going to see too many mills in offices going forward, but we're going to see scanners in every office. And we're not going to be scanning for impressioning. We're going to be scanning for modeling the patient, for empirical data, accurate data in all three dimensions in full color. You're automatically charting restorations. You're charting accurate color on gingival inflammation. You can turn and twist these things. You can mount them virtually. So no more articulators, no more impression materials, trays, all these SKUs, autoclaving stuff. It's really going to change everything. So I am so excited. I ran out and bought a ThreeShape scanner as soon as they came out, just like I did early on in a sensor. We're using it in our imaging centers. And I really think 2 minutes to scan a patient upper and lower arch, that saves you 10 minutes chairside, just charting the patient, what restorations, what teeth are missing, and all of that. So I don't think people understand yet the true value of this technology, but they're going to real quick. 4D, we're talking 2D, 3D, 4D, where occlusion, overlaying, occlusal data on these models. It's just going to be amazing what imaging is going to do for the profession.
A couple of things that I think the lowest hanging fruit on being a better dentist has always been magnification. I mean, if you can go from naked Homo sapien eyes to loops 2.5 to 3.5, you're a better dentist.
Yeah, absolutely.
Scanning, no dentist has ever scanned a prep and seen their prep the size of a screen and not put their tail between their legs and went back to that prep and cleaned it up and did some more stuff. I like that. But I want to challenge your numbers. You said CAD/CAM, chairside milling, the adoption rate was 20%. There's 150,000 general dentists in the United States. 20% would be 30,000. I almost think it's half that amount. I only think
I'm saying it's going to cap out at the very most that. And then these aren't my numbers, but this is good, good
so
research.
So you think it's going to cap at 30,000?
I think it'll cap maximum 20% of market. I'm kind of buying into
which would be 30,000 units.
If that, yeah.
Yeah, and where do you think it is now?
I would say it's much less than that. I'm not sure.
I'd say it's half that amount.
Yeah, I would say about half that.
The point I'm making is my homies are smart. I mean, all my friends have 8 years of college and are a doctor of dentistry. And what do you think the adoption rate is right now in 2017 of digital X-rays?
I knew I was going to be asked that. I haven't bought the latest paid-for research yet, but I would guesstimate it in the U.S., right?
Right.
65, 70.
Okay, so if 65% bought digital X-ray and 20% bought chairside milling, that's a huge red flag that it must not be faster, easier, higher quality, and lower cost. And a lot of people bought that chairside milling and now it's the most expensive coat rack you've ever seen because
Yeah.
what you said earlier, you never thought, why does a doctor digress into become a lab tech? And all these
Exactly.
people in the lecture saying, oh yeah, you can do this in an hour. But out in the real world, that hour is 2 to 3 hours. And
Yeah.
they're sitting there thinking, I'd rather just prep, scan, and send that to the lab, temporize, and leave. And in fact, the people I know that are my friends that are using the chairside milling the most, they're not even milling them chairside anymore. They're just storing all the impressions. Then they have a lady who works in a dental laboratory Monday through Friday 8 to 5, and she comes in one night a week on a Wednesday and mills out all the crowns that they've impressed in the last week. So yeah, doing lab work chairside. I think it's proved by the adoption rate. I
Yeah.
think
I agree.
the adoption rate is the same thing when I got out of school with lasers. When they came out with those lasers in '87, I think the first one was some YAG laser. But anyways, 50,000. And I noticed every time a laser came out for 50,000 in the '80s, 1,000 dentists would buy it, and I'm convinced that 1,000 dentists would buy anything. But it always stopped at about 1,000. You know what I mean? And the true between bleeding edge and leading edge and all that is the adoption rate. But yeah,
One of the greatest companies in the world right now in dentistry is ThreeShape out of Copenhagen. They are killing it. They're growing so quickly. Their products are amazing. They're fast. They're accurate, and they're pricey. They're at the top end of the price scale, but I really think that is an amazing, out of nowhere kind of company that is really going to dominate our profession going forward.
Well, it's so expensive because the U.S. dollar is at an all-time low against the euro. So as the dollar's crashing and the euros, and that's why exporters always want a weak dollar for that exact reason. I mean, nobody at ThreeShape wants a strong euro. They wish the euro would crash. And so when the dollar crashes and the euro gets strong, everybody in Liechtenstein and Germany and all those companies are cringing. But
that's
it's okay.
a product in our product line, the ThreeShape. It's a distributed product for us, but we really think it's the best of breed out there right now across the board. And crown and bridge, implant dentistry, ortho. Now they've got a direct link to the Form Labs printer. That is a killer little printer for those who want to do some in-office printing at a very good price point. That is disruptive to all of the Envision Techs and all these other higher price printers. They got biocompatible materials, provisionals, splints, guides, very, very cost effective. And and they did the deal with Align Technologies. I'm not sure how that's going, but so Align opened up ThreeShape, so that'll continue to fuel their growth, I'm sure.
Yeah, that is definitely a company to watch, isn't it?
Yep, I see.
Yeah. So, anything else you want to talk about?
No, Howard, that's it. Our paths haven't crossed, and I've never sat down with you like this, so I do thanks for the opportunity, and it's been a pleasure to sit down with you and chat.
The honor is all mine. I love technology, but like I say, I always hold up 4 fingers. Is it faster, easier, higher quality, lower cost? And people always come up to me. They always come to me with all these ideas and products, and I always ask them those 4 things. And when you answer yes to all those things, it's amazing. But I really hope you do that online CE course because I really want dentists to go from being molar mechanics to physicians of the mouth, and I really want them to take this oral cancer, Gardasil. I just think you would feel horrible if some little girl came to you every 6 months and then goes to college and gets oral pharyngeal cancer because you never even had a vaccine shot with her. You never even had the talk. And the oral cancer, that's our deal. And I hope you make that on. So what was your lecture on? What's your online CE course going to be on?
It's going to be on. I'll have to change it a little bit to make it, a little bit more pertinent to oral cancer, but it's going to be on salivary diagnostics and an introduction to salivary diagnostics. I think the profession needs to know what's happening out there and what's coming and what's already there in some places, and tie it back into oral cancer screening. I'll come up with something there, and I'll be happy to do that. And maybe just a parting word. You mentioned that your audience is of the younger crowd. You know, my advice to the younger crowd, the younger dentists and students would be that it's really important for them to embrace technology. Patients expect it; they almost demand it, and it's takes a lifetime to be a good dentist, but it only takes like 5 or 6 minutes to look like one. But technology will really allow you to leverage so many parts of your practice in terms of workflow efficiencies and reduction in lab fees and all that. And unfortunately, a lot of these new dentists, I think, are ending up in practices that don't have technology as associates, and so you're going to have to be a bit pushy to get some adoption there. And the other thing, of course, which is not novel, is that it's a lifelong learning experience, and I was able to sell dentistry using imaging and not being able to deliver it, and I had some bad failures. So it's always important to you never stop learning, and join a study club, sales study club or your local study club, and get switched on and plugged in to your community that way, to your mentors.
You're right. First impressions set in lead. Like when it comes to sterilization, every complaint I've heard about a dirty dental office, I mean, the patient doesn't know what an autoclave is. They don't know what a Statim sterilizer is. They don't know anything about autoclave sterilization. But these little ladies tell me, well, there was dust on the baseboards, and there was, and the bathroom didn't have any toilet paper, and she converts a stain on the seats in the waiting room, dust on the baseboards, and no toilet paper as you probably don't clean your instruments. And I also read a deal that when you walk into an operatory and you have a pad, on Wi-Fi, and you do their patient chart on a Wi-Fi deal, that millennials think you're the highest tech guy in the world because you got a little stick pen and you're doing it on the pad. I've seen dental offices where instead of saying, hey, fill out these forms, the receptionist will get up, walk out there, sit next to you with a tablet, and fill it out with you, and people just think you're Star Wars. And, yeah. But, okay, well, hey, we were talking before the show that we both did 23andMe, and I was jealous because I turned out to be 4% Neanderthal, and you're only 1% Neanderthal. I always wondered because my knuckles do drag when I walk, but that really is going to be state of the art someday, isn't it?
Yeah, no, and I think it'll be a point of care test at dental offices for risk assessment pretty soon.
Yeah.
Those type of tests, yeah.
All right, well, thanks so much for coming on the show.